So our next speaker before the questions is Dr. David Metz from the University of Pennsylvania, a gastroenterologist par excellence and with a commitment and special interest to neuroendocrine tumors. And I think it's my pleasure to welcome him and to say hello to him. Thank you.
Thanks, Tom. Good morning, all, and thanks, Tom. I really do appreciate being here. I think New Orleans is a wonderful, wonderful spot. Thanks, Gene and your team for inviting me, and to the NCAN people, of course. It's a great conference. I'm really impressed to see how many people of you have come. I'm going to talk about the role of the gastroenterologist in the diagnosis and treatment of neuroendocrine tumors, and I'm going to work out how to move these slides in a second, I think. There we are. Okay. So some of this is a little bit repetitive, but I'll try and move through those parts quickly. As you all know already, neuroendocrine tumors are actually a lot more prevalent than one would think. They're the second most prevalent cancer in the GI tract behind colorectal cancer. There are over 100,000 people in the United States with metastatic disease, and I think that's actually an underestimate. And the principles of care for this group of diseases is very, very different compared to other solid tumors. And therefore, it's important for us to really get the word out as to the management of patients with NETs. So you've heard already about the increasing incidence, and I don't want to harp on that too much, but I do want to remind everybody the reason why neuroendocrine tumors are so different is that they really have this upside-down presentation. This is a slide from Rod Pommier in OHSU. On the left, you see a classic neuroendocrine, solid tumor in which the primary tumor at the bottom of that triangle is big. The metastases in lymph nodes then grow, and ultimately you get spread more distantly. So the bulk of the disease is where the primary tumor is. Neuroendocrine tumors, on the other hand, on the right, are sort of the upside-down tumor. You can have a tiny, tiny little primary with a big conglomerate mass of lymph nodes and a large bulk of metastasis sitting in the liver. And because of that, the management of patients with NETs is very, very different, because it's not even that important to worry about where the primary is or what it is, as long as you've got its products under control, and we'll talk about those. But it is the bulk of disease in the liver that causes all the problems down the pike. So that controlling this is important as opposed to necessarily trying to cure it. Neuroendocrine disease should be seen as a chronic disease like diabetes, hypertension, and as you can all see, looking at the people in the audience here, many people have widespread disease for many, many, many years, and the challenge for us as clinicians looking after neuroendocrine patients is to keep them healthy for as long as possible while more and more treatment modalities come out. So think of this as a chronic disease, not as a classic cancer. There are three patterns of presentation for neuroendocrine tumors. Excuse me, that's not my stomach. The hormonal syndrome, in which the clinician has to put two and two together, it requires expertise and it requires experience. Tumor symptoms from tumor growth, which occur late in the course of disease, and occasionally, as you've heard already, incidental findings. People who just end up getting a colonoscopy for screening, have a little ditzel. People who get an upper endoscopy for abdominal pain and are found to have something there. So those three patterns you need to think of. The first one's the important one, because you've got to identify those patients if you're clever enough, early enough that you can cure it. The second situation is unfortunately not a curable situation. And the third situation really depends on what is found at the time. Remember, surgery is the only curative modality. That doesn't mean you would only operate if you can cure. And as has been shown in New Orleans, of all places specifically, extensive debulking surgery, I personally am a very firm believer in that. So there are over 90% of the patients with neuroendocrine tumors are originally treated for the wrong disease. And the average time to diagnosis is 5 to 7 years. That's really a travesty, unfortunately. The problem is you're looking for that needle in the haystack, and I'm going to give you a couple of examples, and I'm going to go through some of the syndromic presentations. So inflammatory bowel disease or irritable bowel syndrome, those are two different conditions, are the most commonly misdiagnosed for patients with midgut carcinoids that have the carcinoid syndrome. And I'm sure there's 15, 20, 30 people sitting in the audience who were told, well, you're a middle-aged female, you're starting to go through menopause, you've got irritable bowel syndrome, don't worry about it. And by the time it was ultimately diagnosed was many years later. So the diagnosis is often not made until there's widespread disease. So we're going to go through a couple of case presentations. Don't worry about all the medical stuff here. I'm just going to try and paint some pictures. So the first case is a 47-year-old lady, postmenopausal, long-standing history of irritable bowel syndrome with diarrhea, came to the emergency room with cramping abdominal pain, nausea and vomiting, and she hadn't had a BM for 24 hours. She's really sick at this stage. The physical exam confirmed that she was quite ill. She was flushed, she was hypertensive, her heart rate was rapid, she had a low-grade fever, and her abdomen was all swollen and distended. She had an abdominal X-ray that showed air fluid levels, which are suggestive of an obstruction in the bowel. They put a nasogastric tube into her, they got a couple of liters of fluid out of there, and she said, whew, I feel a lot better. Now was the time to work out what is actually going on with this patient. So when looking at her past history, she gave a history of many years of diarrhea that was told it was irritable bowel syndrome. They were non-bloody, they were watery. It originally responded to over-the-counter therapy, but now she'd been waking up at night needing to go to the bathroom. She'd been incontinent for the last 6 months. Pain had become far more progressive. She also mentioned that she'd been on hormonal replacement therapy for early onset menopause. And if you put all of this together, is this truly irritable bowel syndrome or not? So these are the questions. Why isn't this irritable bowel syndrome? What are the clues here that this could be something else? What's really going on? So the carcinoid syndrome, you've heard already about this a couple of times today, has a bunch of symptoms that together present as a syndrome. A syndrome is a collection of symptoms as opposed to a diagnosis, and that's the problem because there are many potential causes of a syndrome. Flushing is the most prominent, diarrhea the next most prominent. Heart valvular lesions, I agree with the earlier speakers, not as common as they used to be, but they are a presenting feature on occasion. Cramping, abdominal pain, etc., etc., etc. She really has all the features if you sat down and looked at that. So the differential diagnosis that I see as a gastroenterologist when patients come to me and tell them they're having diarrhea is really these 5 conditions listed over here. The most common by far, which drowns out everything else, which is why we tend to miss the diagnosis, is irritable bowel syndrome. Inflammatory bowel disease, Crohn's disease or ulcerative colitis also present with diarrhea, and they're common. 1 in 100 people in America have celiac disease, believe it or not. Not that 1 in 100 people are being treated for celiac disease, but that's a very common condition that we miss, and that's an intolerance of gluten. Lactose intolerance is another very common cause of diarrhea. And then there are all the rare causes like what we're talking about today, carcinoid syndrome. So people don't think about it because there's so many other fish to fry. However, this lady gave us a history of diarrhea. She was flushing. She was told she was in menopause. And as was already mentioned so astutely by our prior speaker, the flush of neuroendocrine tumors in carcinoid syndrome is dry. The flash of menopause is with sweating. And then there are other rare causes as well. So there was a clue here, and somewhere over the last 6 years, potentially this diagnosis could have been made before she developed such a large tumor or so much kinking in the bowel that she actually is now obstructed and blocked, and that's why she had to have the nasogastric tube put in, and now we've got a real problem on our hands. We did work in the past with the Net Alliance, and I see they presenting here today. And this is a table from our Net Alliance pamphlet that gave some clues for when you should think about syndrome. Mostly watery, nighttime diarrhea doesn't occur with irritable bowel syndrome. Bleeding is not common, but it can occur. Constipation is not a feature until very late, as in this case. Flushing, of course, is something you need to ask about. And the pain can be variable. Irritable bowel syndrome specifically, the pain goes away after having a BM. It doesn't necessarily occur with carcinoid syndrome. All right, now let's talk about, and this is the sort of thing gastroenterologists need to see so that you can think about the right diagnosis up front. So now we're going to talk about another gastroenterological disease. A 46-year-old guy has heartburn, abdominal pain, diarrhea over the last 6 months. He's been on a proton pump inhibitor. You just heard about how they impact on our testing in neuroendocrine tumors, but I can tell you half the world takes PPIs. It's the second most commonly prescribed class of drug after the statins. That was because of a documented ulcer, so there was a real reason for the PPI. H. pylori, which is the most common cause of peptic ulcer disease, has been taken out of the picture, and he also takes and he also avoids non-steroidal drugs, aspirin, Motrin, ibuprofen, those sort of drugs, because that's the second most common cause of duodenal ulcer disease. So you've got here a guy who's had ulcer disease, he doesn't take NSAIDs, he doesn't have H. pylori infection. If you're an astute, careful physician, you think maybe there's an unusual cause of duodenal ulcers here. There's no family history suggested of multiple endocrine neoplasia, which you heard about earlier, which doesn't rule it out. Exam, as it is in GI invariably, is unrevealing, and he had an endoscopy that showed a big ulcer with a low gastric pH, power to Dr. Waldron for remembering, you can't get a gastrin without a pH, and then a high gastrin. And that in itself is essentially diagnostic of Zollinger-Ellison syndrome. But this took a long while until this patient was diagnosed. So why isn't this typical peptic ulcer disease? What are the clues? What is the real diagnosis? We've just gone through that. The usual causes aren't there. The medicines didn't help. There was no other abnormalities identified. So Zollinger-Ellison syndrome, or gastrinoma, is a tumor that secretes gastrin, causes acid hypersecretion, and fulminant peptic ulcer disease. And I just want to remind everybody there are two types: the sporadic type, which is more common, and that associated with a hereditary syndrome, multiple endocrine neoplasia type 1, which affects the pituitary glands, the parathyroid glands, and the enteropancreatic system. So think of the 3 Ps. So the presentation of ZE compared to idiopathic ulcer disease, again, is very, very similar. You can get complications. You often get reflux and heartburn. Most important clue is ZE is associated with duodenal ulcer disease, not gastric ulcer disease. And sometimes if you make a lot of pancreatic juice because you're pouring out all this acid and your body tries to buffer that acid with pancreatic juice, up to about 1/3 of patients with ZE don't even have ulcers. They just have overwhelming diarrhea. And that's something that gastroenterologists need to think. But the hallmark is what's called inappropriate hypergastrinemia. And here is the list of appropriate and inappropriate hypergastrinemia. As you've already heard, PPIs cause high gastrin and high chromogranin A. Well, that's because it's an appropriate hypergastrinemia. Your body will switch off acid production from the drug effect, so you don't make any acid, then you make more gastrin to try and restore that acid. That's an appropriate hypergastrinemia. Zollinger-Ellison syndrome, on the other hand, is an inappropriate hypergastrinemia. The gastrin comes from the tumor, drives the stomach to make a lot of acid to give you ulcers. So if I go to this slide over here, and I'll try and show it with the pointer, the parietal cell makes acid. That lowers the pH in the stomach. When the pH in the stomach goes down, that switches on a feedback loop through the D cells, which make a product, somatostatin, that tells the gastrin to switch off and stop making more acid. So if you're on a PPI and you don't have parietal cells making acid, you switch that off, your gastrin goes up. On the other hand, if you have a tumor making gastrin that gets into the bloodstream, comes to the stomach, tells the parietal cell to make a whole lot of acid, that acid causes you to switch off your feedback loop, but it doesn't go anywhere near the tumor, and you have relentless gastrin drive and ulcer disease. Unusual presentation, rare disease, 0.5 per million. Let's move to the insulinoma. I'm going to quickly mention a couple of other functional syndromes. This is a tumor in the pancreas that secretes insulin. The classic features of the insulinoma syndrome is what's called Whipple's triad. So you get hypoglycemic or low glucose levels, and then you eat because you know you're feeling bad, you restore your glucose levels, and you feel relatively well. So the classic presentation here is hypoglycemia with symptoms of a low sugar, sympathetic overdrive, neuroglycopenia, which are sort of the symptoms of insulin shock, and then you eat and it goes away, and that can also go for years and years and years and years and years. Unusual in neuroendocrine tumor land, insulinomas are often benign, but not all. It's the most common neuroendocrine tumor in the actual pancreas itself, because Zollinger-Ellison syndrome is often in the wall of the duodenum. As you heard earlier, duodenal tumors are increasing. And they're generally solitary tumors and can be therefore treated easily surgically. Insulinomas are unique, again, a couple of things. They're often benign, they're always in the pancreas, and they are often of octreoscan negative for some unclear reason. So that the diagnosis in insulinoma is an endoscopic ultrasound, and this is just a picture of an EUS showing an insulinoma sitting in the pancreas over here. Glucagonoma syndrome, another neuroendocrine tumor syndrome of the pancreas. It's the 4 Ds, dermatitis, diabetes, DVTs, those are clots in the legs, and depression. The fasting glucagon level here is elevated because that's what the tumor is making. These patients usually get to a dermatologist, and until they have a biopsy of what they're told is eczema, psoriasis, some other dermatological condition, again, a delay in diagnosis. And I have some photographs here just to give you an idea. These can be really, really severe, ugly, difficult to manage rashes. The Vipoma syndrome, another syndrome in the pancreas, watery diarrhea, hypochlorhydria, hypokalemia, and achlorhydria, also called the Werner-Morrison syndrome. This is a tumor that makes VIP, vasoactive intestinal polypeptide, that gives you overwhelming diarrhea. Again, often present late because that diarrhea is confused with IBS, IBD, etc., etc. So you've already heard about Ghrelin and all the other products that we're learning about. There are many, many syndromes coming up. On my left is one of the preeminent endocrinologists in this field, and I'm sure that Tom can come up with another 20 or 30 possible neuroendocrine tumors. Just want to remind you of the Cushing syndrome from the ACTH-producing tumors. Acromegaly is caused by a growth hormone-releasing tumor. There even is a somatostatinoma syndrome, even though we use somatostatin to treat these tumors, and then a whole lot of other rare ones. So, management principles. I'm not going to get too much into management, but I do want to go through what we do and then show you a tour of the quick GI tract endoscopically. So, confirm the diagnosis, most important job we all do because often people get mislabeled. Control the hormonal syndrome, because that gives you a lot of difficult symptoms. Determine the extent of disease, because you're going to assess, is it curable, debulkable, how are we going to manage this? Control the tumor growth with whatever modalities you have at hand, and I would focus on the fact that management of this disease is multidisciplinary, requiring endocrinologists, gastroenterologists, oncologists, surgeons, radiologists, etc. Now, it's important to realize that syndrome must be controlled, and as an example, I'm using here the carcinoid syndrome. This is a famous presentation looking at patients with carcinoid syndrome who had no current tumor, in other words, were cured, in the solid blue. The hatched blue is those who had the tumor but weren't syndromic, and the lighter one is those who had tumor and still had carcinoid syndromes. And whichever you want to measure it, the actual syndrome had a worsening impact on quality of life over and above the tumor itself. So how do we control syndrome? Well, somatostatin analogs, as you all know, octreotide, lanreotide, pasireotide for some conditions, have been devised as long-acting somatostatin analogs that block the production of hormonal products from these tumors, and they are really very effective. I'm sure many people in the room are on those therapies. They're the drugs of choice for syndrome management, and they have been FDA approved for carcinoid syndrome, vipoma, and acromegaly. That doesn't mean you shouldn't use them for other things. You should. It's just that because of the rarity of the disease, studies haven't been done. Lanreotide specifically approved for acromegaly. There are second-line considerations for gastronoma, because in gastronoma specifically, you can block the proton pump with PPI drugs. So for syndrome control, you don't need an octreotide or lanreotide analog. However, what's also important, as I'm sure many of you know, and we saw the PROMID trial, there's the PROMID trial with octreotide and the Clarinet trial with lanreotide. These analogs control tumor progression, so that's another important reason to use these drugs. There is a new drug coming out that is now under FDA review. And this is a drug called telotrestat etoprate. We've had a number of patients in the trial at our institution. We're anxiously waiting approval because we have many others that we think would qualify. This is an oral drug that blocks serotonin production. It doesn't get across the blood-brain barrier, so it has no impact on mood, we don't believe. It has been shown to reduce 5-HIAA levels, flushing, and diarrhea, and to be relatively well tolerated. In fact, in my own personal experience with our patients, we had a fair amount of constipation in the open-label trials. And I think this drug hopefully will come out soon and will be a useful adjunct for patients with carcinoid syndrome whose tumors are stable and not progressing, but who are still getting syndromic features. Okay, now we're going to run in the next 9 minutes and 58 seconds on staging of disease. And I probably will go a little long, I'll try not to. Endoscopy. You can do optical endoscopy when you look with EGD, upper endoscopy or colonoscopy. Capsule endoscopy is swallowing a camera. Deep enteroscopy, you already saw from Dr. Warner about the double balloon, single balloon spirus. And then endoscopic ultrasonography, such as EUS, especially for the pancreas, most importantly. I'm not going to focus on cross-sectional studies, either routine MRI, CT, or functional imaging, Octria scan, MRBG scan, the upcoming gallium scan. So the endoscopist's job is to realize that the vast majority of nets are in the GI tract somewhere, and that with modern techniques now, we can actually see every single part of your GI tract, the whole way, top to bottom. The newer techniques, including these double balloon techniques, allow us to put needles through the wall of the bowel and actually get biopsies, to place tattoos so that the surgeon can find them at a later stage, and to do ultrasonography through probes. So there's all sorts of things we can now do. And we're going to run through the GI tract. We'll start at the top with gastric carcinoids. As you've already heard, the most important point with some of these tumors is to say, do they occur in the presence or the absence of acid production? Is the gastrin appropriate or inappropriate? So we can type gastric carcinoids as type 1, type 2, type 3 based on an upper endoscopy, and I'll show you that in a little while. You can also endoscopically remove larger lesions with what's called an endoscopic mucosal resection. You inject some dye underneath the tumor, you lift it up off the muscular wall, and then you put a snare and lasso around it and cauterize it out. You can also do endoscopic ultrasound to see how deep it is infiltrating the wall. Is that safe or not safe? And especially for a type 3 carcinoid, which is the highly malignant one, if you can't get it off, then you need to send that patient to surgery for a wide operation. So this is my management algorithm that I've used now for a number of years. You start at the top. You do a gastric pH and fasting gastrin. If the gastrin is high and the pH is high, that's a type 1 carcinoid. It's the one associated with atrophic gastritis, pernicious anemia. As you can see, that's a relatively low risk region. Although you individualize therapy, I'm not too anxious about that. In the middle column are people who have a low pH and a high fasting gastrin. That's a type 2 gastric carcinoid associated with MEN1 and Zollinger-Ellison syndrome. And there you got to look for all the other associated diseases. So you must get an O scan or a gallium scan, and you got to think about the pituitary, the parathyroid, the pancreas, and treat the whole patient. The scary one is those that have a normal pH and a normal gastrin. That's a type 3. You must get an endoscopic ultrasound. That's potentially invasive, and that patient is potentially going to the operating room if you're going to try and cure that condition. And they vary in presentation. So on the left, you see a type 1 carcinoid that I remember in an elderly lady. We even elected to leave all of these alone. Look at them. How do you treat this? You can take out the whole stomach. That's morbid. I think there's an argument can be made to put this patient onto octreotide or lanreotide to shrink them up. The patient on the right is another person with pernicious anemia and atrophic gastritis, and you can almost miss those small little carcinoids that are sitting there. So individualized therapy is important. Type 2s, this is an example on the left of a patient of mine who had 2 big type 2 carcinoids in the stomach with MEN1 and ZE. You can see on the O scan above that there were 2 hot spots. After we took them off with a snare, there was only 1 hot spot. The hot spot was the duodenal gastrinoma that this patient also had. And here's a type 3 gastric carcinoid in the stomach that's rather large, that's necrosed centrally. It's sort of dying out. It's outgrowing its blood supply because it's an aggressive tumor. And you can see that it's got that central umbilication. That was a risky lesion that needs to be treated very carefully. Duodenal carcinoids, as you've already heard, are increasing in incidence. We don't really know why. I think it might be medicine-related to some extent. They can be isolated or multiple. Isolated lesions can be taken out endoscopically. However, multiple lesions in MEN1 are not as easily managed. And you can see here the variability of the duodenal carcinoids. On the left is an MEN1 patient with multiple tumors, and on the right is a tiny little disease, the gastronoma in the duodenum that you could only find in the operating room when you shone a light through the duodenal wall and the surgeon was holding it in his hands. So having inappropriate hypergastrinemia is enough to go to an operation, even if you don't know where the tumor is on imaging, because you could potentially find a tiny little thing like that and cure it. Endoscopic ultrasonography, I'm not going to harp on this, and I see my time's running away here, but here's a photograph of an EUS with a lesion and a needle being placed through the wall under ultrasound guidance into the lesion to sample some tissue and actually make a firm diagnosis. Small bowel carcinoids, you've already heard about. Video capsule endoscopy, very useful. Deep enteroscopy, you've heard from Dr. Warner earlier about this. And just to give you a couple of pictures, there's a capsule endoscopy showing a bulge. Unfortunately, you can find it, but you can't do much about it. And so the way to deal with it is with double balloon. You've already heard about the whole technique of double balloon and how it works. And here's 2 X-ray pictures just to show you that we really can see the entire GI tract. That's from below going all the way up, and that's from above going all the way down. An example of an ileal carcinoid, a small bowel carcinoid seen on double balloon enteroscopy. We'll end off with colonic carcinoids. They're often discovered at routine screening, as we've already alluded to. So we're seeing more and more of these little ditzels. Gastroenterologists call me up once a week. I took out a tiny little polyp, and lo and behold, it wasn't a polyp, it was a carcinoid. What should I do? The important thing is go back immediately before that scar heals so you can find the lesion and biopsy the walls and make sure that it's all out. Because anything under a centimeter in size that's all out is cured. You also can do endoscopic ultrasound there if you're concerned to look for associated lymph nodes if it's a larger lesion. But they do, and the gastroenterologists need to realize they look different. They're normally yellow, and they normally give a crunch when you take it off with a snare. So if you're experienced, you can actually tell that this was a carcinoid and not a simple polyp. Here's an example of a terminal ileal carcinoid prolapsing all the way into the cecum when somebody was doing colonoscopy. So when people have screening colonoscopies, they should really try and get through the ileocecal valve and not wait until they're big enough that they prolapse through. So every colonoscopist should look at the terminal ileum, and often they don't have time or ability to do that. Here's a small little rectal carcinoid. On the left, you see it. It's flat. It's a little bit yellow. It's got normal overlying tissue. It looks different from a classic polyp. The middle picture is a picture with an injection underneath it to raise it off the muscular wall. And the picture on the right is after the lasso was placed around and it was cauterized out. This lesion is cured. No need to worry about it going forward. However, as I've already told you, what happens more often than not is they call me back and say, well, now what do I do? So we go back and do a completion resection on occasions. And what you can see over here in the first picture on the top left is this little bump over there, which was the residual, which we were able to find. We have a cap over the end of the endoscope. We suck the mucosa, the lining of the bowel, into the cap, and then we place a band and snare around it and end up with another defect, as you can see on the bottom right. So we've cleared that area for that patient. I'm going to end off, and I'm actually going to make it on time, Don. Tom, I'm very impressed with myself. 2 more slides are very important. Managing the effects of therapy. As a gastroenterologist, we have to realize that when we treat patients with neuroendocrine tumors, we often cause disease, and we have to think about the impacts of our therapy on patients. And here are a few examples. From pancreatic resections, which can either be a distal resection or a Whipple's operation, you end up with pancreatic insufficiency. So you're not making enough enzymes, you're not digesting very well. You can replace that with enzymes. You get the dumping syndrome because you get discoordinated movement in the bowel relative to all the secretions of bile and pancreatic juice. And you've lost the neural control. Diabetes is a common problem, either from octreotide, lanreotide therapy, or because you don't have much pancreas and you've lost your insulin production. And also, before anybody gets a pancreatic resection, because they may lose their spleen, it's important to inoculate for encapsulated organisms because you don't want to get infectious complications. As I've already alluded to on the top right, octreotide slows down the bowel, gives you a lot of steatorrhea and malabsorption because you lose your pancreatic enzymes. You also can get gallstones from octreotide, and that's why prophylactic cholecystectomy is recommended if these patients ever get to surgery. Adhesions in the bowel are important because they can cause obstructive symptoms. And anybody who's had the terminal ileum resected as part of a carcinoid syndrome surgery, remember vitamin B12 is absorbed there. B12 deficiency is a big deal. Bile salt diarrhea is a common cause, so it's not all syndromic. And bacterial overgrowth is another common cause of diarrhea. Patients need to be aware of these things because often their physicians focus only on the tumor. And the second to last slide, now I'm flashing. I'm flashing or flashing? Multidisciplinary care, I've already alluded to this. There's no standard algorithm, there's no standard management, every patient's different. A tumor board is essential wherever you get your care, because if you've got a hammer, everything looks like a nail. So if you're a gastroenterologist, you're going to scope. If you're a surgeon, you're going to cut. If you're an endocrinologist, you're going to find some hormonal management. If you're an oncologist, you're going to give chemo. But you should all get together and decide what's right for Mrs. Smith. And that's really very important. So I've taken you on a very quick tour through gastroenterology. NETs present in varied ways, have many features in common, but differ from other solid malignancies. Management requires attention to tumor growth and the syndromic features. Surgery is the only curative modality, but it's also effective for debulking. I haven't focused on liver-directed therapy today. That's another method of debulking that's really important. Somatostatin analogs are the drugs of choice for syndromic management and tumor growth. Staging is achieved with cross-sectional and functional imaging. We didn't touch on that, but endoscopy is important. There's no clear algorithm yet for systemic therapies. We haven't spoken about that, but you'll hear more about it. When to do which therapy. I think that's the biggest challenge we have as a field right now. But multidisciplinary care truly is the norm. And thank you very, very much for your attention. It's a pleasure to be here. And let me just say, my son is at Tulane University, so I come down here whenever I can, and it's a wonderful place to be.